close to his eyes or any of those kind of things. And this is not going to be the permanent securement here. Now, as I'm going through, you'll notice that I always keep the tube above the patient's shoulder level. If you let it hang down like this, you're going to potentially have secretions draining down the tube. So anytime you have the tube in the patient, always keep it up at this level. The best way to confirm placement would certainly be a chest x-ray. You're not going to see that with every use of your patient's tube. So more than likely, you're going to be coming back over here and using the gastric pH. You're going to be measuring the length of the tube, or you could use the method we were talking about where you instill the air. So the next thing I'm going to do is come over here and grab my piston irrigation syringe. Anytime I manipulate the tube, I cannot open the tube without having it clamped off, which means I actually have to come down here and clamp the tube. That way I prevent air from entering the patient or secretions from escaping. Now at this point, what I'm going to do is confirm with gastric the whoosh, which some of your facilities do. And what they would tell you is you need to draw up either 5 to 10 milliliters of air, actually attach it to the port. Now I can unclamp. I would now put my stethoscope in my ears, and I would come down and I would put, and let me do this real quick and make sure it's above your patient's chest level. I'm going to put the stethoscope on. I'm going to find the patient's epigastric area and make sure and place my stethoscope there. As I instill the air, I'm going to be listening for a whoosh. Then I'm going to take my stethoscope back. Now I'm going to move over and I'm going to actually pull back or aspirate some gastric contents. Once I get the gastric contents, I then need to clamp the tube again, making sure I'm not pulling on the tube or dislodging it in any manner. I can take the anti-reflux valve and reclamp the tube, and then I can let go of it. I'm going to come over here and put the gastric secretions down on the pH paper that I have. Be careful because sometimes it can splash up on you, so if you wanted to wear a mask with a face shield, that would not be unheard of. Once I squirt this out on there, I actually want to look at the gastric pH, and again, your textbook says that the pH should be less than 5.5. Most of your gastric secretions are probably 0 to 4. Always make sure as well, and note that if you have tube feedings infusing or if you have medications going through the tube, that they could potentially change the pH of the gastric secretions. So now I have confirmed by whoosh of air, I have confirmed by gastric pH. I would have my irrigant in here because I would need to go ahead and clear the secretions of this line. So I would go ahead and I could pull up the ordered amount of irrigant. I could come back over here. Again, I need to clamp the tube off before I open it up. Open up the port, and then go ahead and instill the amount of liquid. Clamp the tube again, and then go ahead and reclamp with the anti-reflux valve. At this point, we have discussed verifying placement with a chest x-ray. We've discussed verifying placement by listening over the epigastric while inserting air if your facility policy states that. We have discussed verifying placement with the pH paper. The other thing that you can do is, either now or later or both, you also can come and you can measure with your disposable or reusable, but I would need to take this off of the patient's cheek to do this. So typically we would do this once we've secured it completely. If you feel comfortable, you can come and take this loose, and be careful with his neck and stuff. Certainly you don't want to peel his skin or cause him any discomfort here with his cheek. And I can come now and I can measure from the nair all the way down the tube, making sure that I'm not pulling the tube or dislodging it. And I could measure all the way to the tip end of the tube, which is the end of the clear plastic piece down here. And as I'm measuring this, I usually do it in centimeter marks, and you want it completely out, and it looks like it's up to the 79.5 mark. The next thing I'm going to do, certainly I'm going to maintain grip on the tube. I can now come up here and I can grab the skin prep, and I would put it on his nose and I would allow it to dry. And then whatever securement device I have that I can use for Mr. Smith, I would come, and most of the time they will stick to the nose in this manner and then wrap around the tube in this manner. For the sake of us being able to see it, I'm going to go ahead and use a clear piece of tape so you can continue to see what I do for the procedure. Some agencies, you will see that they will come through here and they will actually tear the tape and have two little slices like this. You'll put one on the patient's nose, making sure you don't get it in his eyes. And then you can take and wrap one side around the tube and then take and wrap the other side around the tube. And again, at the end of it, you may well want to go back and confirm that it is at the mark that it was at the nose when you started. You can come back again and you can measure again. And anytime you come into the room to use the tube or to do anything with it, you always have to reconfirm placement. And one of those ways would be based on your agency policy. It could include injecting the air and listening over the epigastrium. It can include the pH, and it also includes measuring the length. And you can get in the habit of doing all three, which would definitely confirm placement. At this point, I have now inserted the tube, so I need to make sure that he's not having any distress. Make sure to go back and reassess him at this point. Make sure there isn't anything that I have forgotten to do. If I needed to attach him to suction, I could do that at this point, but we're going to do that in a different video. So before I get done, I need to go through and clean up the equipment and make sure everything's okay. First, I'm going to change my gloves because they may well have gastric secretions on them and all that stuff. If he did throw up throughout the procedure, I definitely want to go ahead and get the vomitus off of here and clean it up. He did not do that. We were fortunate. We could go ahead again and take off the dirty gloves. Your hands are probably sweaty at this point. As you've been in here doing it, you've probably been nervous. It's hot in the room. Go ahead and foam again. You're going to want to put on some clean gloves before you clean up the rest of the equipment if there was vomitus or anything here. Again, I'm going to go ahead and remove the waterproof drape from the patient, and I'm going to get his cup of water and tissues, if he doesn't need them anymore, out of the way. And the next thing I need to do is make sure and secure the tube to the patient's gown. Okay? Now, as I'm doing this, you'll see that I always keep the tube above the patient's chest. And when I come through and do this, I want to make sure again that I don't stick the needle through the tube. You also want to make sure the patient turns their head to the opposite side. So when you do secure it, it gives them enough room to move with the tube so that it's not pulling on their nares and possibly pulling the tube out. So very often what we'll do is come and with a rubber band, wrap it around here and through. If I can get it to do this today. Hang on just a minute. I did it earlier. There we go. Once I've got the rubber band on there, and I'm not pulling on the tube while I'm doing this, I'll go ahead and stick the pin through the rubber band, and then again attach this to the patient's gown while the patient has their head turned so that I can make sure they have enough room here with this. An alternative method would be to go ahead and put a piece of tape around the tube and actually stick the pin through the tape and then adhere it to the patient's gown. Again, always make sure that the tube is up above the patient's chest level so that you don't have any drainage back down the tube. Go ahead and reassess him at this point. Make sure he's not having any difficulty breathing. We could potentially put his head down some here. Of course, we would lower his bed and make sure that we have addressed the 4 P's, okay? And positioning is one of them. So I'm going to lower his head down. Usually whenever you have an NG tube in place, you do not want to go any lower than semi-Fowler's position because this can predispose your patient for aspiration. So I would only go down to that level, but again, if he needed to be moved or any of that, I would address the position. Before we started, if he was in pain, I could have pre-medicated him. Now that we're done, I'll ask him if he's having any pain. Certainly he's saying he's having some discomfort from the tube. That is normal. Sometimes they'll order pre-anesthetics before you put the tube in. It depends on the policy and your orders of your physician. We would provide for mouth care. There may be lozenges and some of that kind of stuff that could assist with that. So we've addressed pain and positioning. Proximity, I would need to make sure that he's got his call bell, and I would pull the table back over here whenever we're done, and I need to make sure that he doesn't need to use the bathroom. Currently, this tube is what we call clamped because it is not attached to suction. So if he needed to get up with it, we could do that, and he could either urinate or use the bedside commode. If he was attached to suction, we would probably need to discontinue that before he ended up with that. If he was having tube feedings, we might well need to do the same thing, or else he would need to be in the bed. Certainly if tube feedings were attached before we lowered him or anything like we said, we would need to make sure and stop those because he is going to be predisposed for aspiration since this tube is in here. So we've now addressed the 4 Ps. I make sure that he is clean and dry and intact and all that stuff. Make sure and address for safety that his bed is completely low and that it's locked. His rails are here. Again, he's got his call bell and all that kind of stuff. I would finish cleaning up my equipment. I've offered him mouth care and all these things. I'm going to ask him if there's anything else he needs before I leave the room, and then I'm certainly going to thank Mr. Smith for allowing me to care for him today and place the NG tube. Thank you very much. So, I'm now going to move on to discussion actual irrigation and suction of the patient's NG tube. So when I enter the room, remember I always knock and I provide for privacy. I'm going to go ahead and foam in as I enter the room, and I'm going to perform aid it and then discuss the 4 Ps and look at the patient's safety. So I'm going to acknowledge Mr. Smith. Good morning. My name's Heather. I'm going to be your nurse today. I've introduced myself. I'm coming in and I'm going to actually check placement of your NG tube again, and I'm going to irrigate a little bit, make sure it's functional and connected to suction that the doctor has ordered. So I've explained what I'm going to do. I've given him a duration. It's going to take probably about 10 to 15 minutes at most for me to do this. And before I leave the room, of course, I would thank the patient for allowing me to care for him. I need to go through again and always identify my patient and look at his armband. And sir, could you please repeat your name and date of birth for me? And as he's doing that, I'm going to look at his armband, and I'm going to ask him if he has any allergies to anything, and he says that he does not. So I'm going to go ahead and raise the bed up to working height at this point. And then I need to make sure that Mr. Smith is at least up to semi-Fowler's position. Anytime I come in and I'm working with an NG tube, I always need to make sure that I check placement before I get started. Now, in the last video, you will have noted that there are several different ways to check placement. Certainly, the X-ray is the most reliable, but they're not going to do that every time that you're working with the patient's NG tube. So the next thing that I would do is I would move on and I could measure the length of the tube. And we're going to do that in just a minute. I can check gastric pH, and we're going to do that in just a minute, and then we can inject air through it and listen for the whoosh in his stomach. Before I get started with this, however, after I irrigate the tube, the doctor has actually ordered suction, and I would need to have checked the order and all that stuff before I come into the room to see what they order. Typically, they order what we call low intermittent wall suction, and so what I'm going to do is I'm going to back up over here to the actual suction control, and I'm going to set up his suction at this point. So whenever I come over here to do this, I'm always going to have on one disposable glove. And we're actually over here at the suction control at the bedside. Whenever I need to set up the suction, I need to go ahead and turn it to regular or continuous, at least to set the suction initially. I need to get the end of the suction tubing, and I need to make sure and adjust the suction to what we would call low suction. And if you look on this one goes up to about 60. It depends on the suction control that you're using, so make sure you look at your hospital policy to see what it defines low suction as. You also need to look at your suction control, and for this one the low would roll down here to about 60, and then I need to make sure I go ahead and include it intermittently, and I need to adjust it so that it does not go above that mark whenever it's actually occluded. And it will do it intermittently, and so that's why I'm suctioning intermittently. I've now established the level of suction for whenever it's actually occluded, that it is within the low range. At this point, I'm now going to flip it over to the intermittent range, which means it cycles on and off, and that is the way the physician has ordered the suction, is low intermittent wall suction. The next thing I'm going to do is move this over here, the tubing, to the patient's bed, and then I'm going to move on with checking placement and doing the irrigation, and lastly connecting him up to the suction. All right, and now that I've established the low intermittent suction, I move the tubing over here to the patient's bedside. I'm going to go ahead and take off this glove, and I'm going to foam again. I'm now to the point where I'm ready to check placement and all those things, so I need to put on some new gloves. Please remember that in between when you're foaming, it can make your hands sticky and sweaty, and so you might have to adjust the size of your gloves as you're going and putting these on. But you always want gloves on during this procedure because you can be exposed to gastric secretions. So once I get my gloves on, I'm now going to make sure that I had brought the appropriate equipment in with me before I started. I've got some tissues here for Mr. Smith in case if he needs to blow his nose or any of that kind of stuff as I'm manipulating the tube. Certainly an emesis basin never hurts in case he does end up getting nauseated or anything from the manipulation of the tube. I've got the equipment to check placement and all those things with me, including the pH paper and then my irrigation set. I've also got my stethoscope. I've got the measurement device here, and then I've got an irrigant here because I'm supposed to be irrigating. So the next thing I'm going to go ahead and do, I'm going to go ahead and get, I like to do the measurement of the length first. So what I'm going to go ahead and do is take this loose from his gown by undoing the pin. And I need to make sure that I keep this close by because when I am all completely finished, I'm going to want to secure this to his gown again, of course. I'm going to go ahead and take the tube, make sure I'm not pulling on his nares. And at this point, I'm going to pull out the measurement device and measure from the tip of his nose down to the tip of the tube. And I should have recorded in my documentation what the length of the tube was whenever the tube was placed in, and whoever else did that should have put that in too. And if you'll notice, I'm holding the tube firmly here in my hand so that I'm not actively pulling it out. And again, it is at the 79.5 mark, which is what it was whenever I had worked with the tube before. I'm going to make sure that I maintain it up here above the level of the stomach again. So I've performed the length of the measurement. Now I'm going to come over here and I'm going to get the piston irrigation syringe, and I'm going to draw up the 5 to 10 milliliters of the air. Anytime I undo the tube, remember I must clamp it without pulling on the patient's nose. I'm going to go ahead and insert the tube in. I'm going to let this sit here for just a second. I'm going to go ahead and put my stethoscope on. And I'm going to make sure and put the stethoscope over the patient's epigastrum while I insert the air. And again, listening for a whoosh. Now, some agency policies require that you do that and some do not. At this point, this is still secured. I'm going to go ahead and pull back and aspirate. Once I aspirate, I need to again clamp the tube. I need to take the piston irrigation syringe apart and go ahead and put the anti-reflux valve in again and reclamp the tube. I'm going to come over and squirt out the gastric aspirate onto the pH paper, looking for the actual pH. Again, your textbook says that it should be less than 5.5. Most of your gastric secretions you're going to find are around 0 to 4. Now that I've confirmed placement by measurement, by air, and by pH, remember, again, chest x-ray is the most accurate. So I've confirmed placement. I'm going to come over, and whatever my irrigant that was ordered, I should already have in my set. I'm going to draw up the prescribed amount, and I think your textbook says 30 milliliters, so I'm going to go ahead and draw that up. I'm going to come back over to my patient. I'm going to clamp the tubing again. Once I get it clamped, I can take the anti-reflux valve out and put the piston irrigation syringe in, unclamp. Then I'm going to instill the fluid. Once I have instilled the fluid, I can then go ahead and reclamp, and I can replace the anti-reflux valve back into the tube. At this point, I have irrigated the tube. If I had any issues with the irrigation, I could further go ahead and inject 10 to 20 milliliters of air and further irrigate if I was having some issues. Sometimes the tube gets stuck in here on the stomach wall, and if you instill further air through it, it can help displace it off of that. I didn't have any issues. I irrigated it appropriately. We had already confirmed placement. So now I'm ready to establish suction. There was a piece that actually came with your piston irrigation set, and once you open it up, or excuse me, it comes with the actual Yonker set when you open up the tubing. I would always recommend saving this because this works a lot better to connect your tubing and things. So this would already be in the tubing, and then before I unclamp this, I need to come in and further clamp it manually by hand. I need to take the anti-reflux valve out, and I need to go ahead and attach this, and now my suction is established. But please remember, anytime you always work with the tube, you want to always check placement first, and then you would irrigate or give your medications or establish your suction or whatever you needed to do. Again, this always needs to be above the level of the patient's stomach. The anti-reflux valve needs to stay in here because, again, I have established my air vent. If you ever have any issues with this and you notice drainage down here, or you wanted to get in the habit of making sure there was no issues with it, you could come over here and you could draw up 10 milliliters, 5 to 10 milliliters of air, depending on your agency policy. And you could further come over and take out the anti-reflux valve, and you could push the air through the air vent and reestablish with the anti-reflux valve, and that would have cleared the line of any secretions. One way to prevent secretions from going up there in the first place is always to keep it above the level of the stomach. So at this point, we have come in, we have checked placement, we have irrigated the tube, and we have established suction to Mr. Smith. I now need to re-secure this to his gown to make sure that it doesn't fall and that it doesn't get pulled. So the next thing I'm going to do is come back over here, and I'm going to reattach the rubber band, and I'm going to put the pin through here, through the rubber band, or if you'd put tape on it, you would want to make sure and go through and stick it through the tape, but not the tube. And before I actually attach it, I need to have him turn his head to the side to make sure that the tube is not being pulled on by the actual pin and the securement over here. Now that I'm finished, I can go through and I can remove any waterproof drapes. I can get rid of emesis basins. I can go ahead and get rid of tissues if he no longer needs this, dispose of everything in the appropriate receptacles. I'm going to go ahead and take off my gloves. I'm going to go ahead and foam my hands. And I'm going to go ahead and start talking to Mr. Smith and making sure how he's doing. Before I had done any of this, I would have wanted to have made some assessments, which would include bowel sounds. I would also want to go ahead and make sure and assess for abdominal distension, nausea, vomiting, signs of distress. And at the end, I need to go back through and reassess. That way I have an assessment before and an assessment after to compare to. One other thing to note, when your suction is attached, when you listen to bowel sounds, you will be hearing the actual suction whenever it's coming on and off. So when you need to listen to bowel sounds, you would need to come and turn the suction off and then listen to bowel sounds and turn the suction back on. Otherwise, what you're going to be hearing is the suction cycling off and on with the NG tube. I'm going to go ahead and lower his bed. I'm going to make sure he's in a position of comfort. Please remember that anytime you have an NG tube in, we typically keep your patients at least semi-Fowlers or higher because you are predisposing your patient for aspiration risk. So we've addressed position. I would have addressed pain before we started and pre-medicated him if he needed it. I could medicate him now if he complained of pain, but Mr. Smith is saying he's okay. I'm also going to ask him if he needs to potty. Again, as we stated in the last video, if he is attached to suction, I might have to disestablish the suction before he got up to urinate. That way we didn't end up pulling the tube or dislodging it. And then we also need to address proximity. I would need to make sure that he had his call bell. Once I clean this table, I would need to pull that over here. I also need to reestablish that his bed is low and locked, and that he is in a safe position. And then finally, I need to thank Mr. Smith for allowing me to care for him today and ask him if he needs anything else before I leave the room. Thank you very much.